For coming and sharing with us your experience with semaglutide. It's your turn now.
Dear professors, ladies and gentlemen, thank you very much for your invitation. It's a great honor for me to be here with you at your Congress. My name is Eva Račická, and I work in a outdoor department for patients with diabetes mellitus, and I also work with people with some other internal medicine, but especially with people with diabetes mellitus too. And we work together with my experienced diabetic nurses and with also nutritional specialists for diabetes. Just now, I'd like to start my lecture to present you results of therapy, of treatment with semaglutide, a new GLP-1 receptor agonist with 1 weekly administration, and I will talk on data from clinical practice. These are my disclosures. So, diabetes mellitus, it's a really challenge to treat diabetes mellitus, especially diabetes mellitus type 2. Diabetes mellitus is associated with substantial burden of morbidity and mortality because of microvascular and macrovascular complications. It associated also with other complications, so together with atherosclerosis, hypertension, and dyslipidemia. There is an increased risk of ischemic events, and that risk is really high. We know that today we have got a very rich portfolio of treatment for diabetes mellitus type 2. But we know that it's not easy to put all new treatments into daily practice. So we know that, e.g., for the class of available GLP-1 receptor agonists, it's not easy to overcome some barriers of this treatment, and we know that this class is still underutilized. The answer of the reason is that persistence and medication adherence remains a challenge. We know that to prescribe a complex insulin therapy is a real high barrier. We know that there is that varies adherence between people for oral and injectable therapies. So in general, it's their general opinion that novel strategies are needed to keep patients on the medication. We have already had the results from the development program SUSTAIN. That program has confirmed excellent efficacy of semaglutide in lowering glucose along with body weight reduction. But these are the results of randomized clinical trials. In our practice, we can follow the results of that of the randomized controlled trials, and we know that the patients in these studies are strictly selected, and our population must not correspond with these patients. So we appreciate the results from real-world evidence studies, as these studies collect data from daily practice, so we get information on patients with various age and various background therapy, how they are improving in their daily setting. So the next problem is that results from those randomized clinical trials are not always observed in real-world clinical practice. What's the reason? It is thought that there is a key contributor to that efficacy gap, and it's again that poor medication adherence among people in daily practice. But now I have got promising data for you, as I can tell you the results from the first real-world evidence studies, and this data come from the register in Canada, as Canada and the United States were the first countries where semaglutide has been introduced in the end of 2017. The SPARE study, it's a study where are results from more than 500 people with diabetes 2. And the aim of the study was to evaluate their real outcomes in GLP receptor agonist naive patients who were initiating semaglutide as a part of their usual diabetes therapy. The aim, the primary endpoint is usual, it is change in HbA1c, and of course there were other endpoints. It means fasting blood glucose, systolic blood pressure, diastolic blood pressure, and of course also change in body weight. So when we see that results, we can be satisfied. You can see that all this cohort of this patient was successful in reduction of HbA1c. And this similar reduction of in HbA1c was seen in all subgroups of patients based on their concomitant therapy, including oral therapy or including insulin. And 44 persons of this cohort achieved HbA1c below 7% of DCCT, so it's very successful. So next results are for the change in body weight. Also you can see that there is a good result for all patients, for all cohort of these patients, again in all subgroups of patients when it is based on their concomitant therapy again, and in average it was minus more than 3 kilograms for a patient. So let's go to the United States. United States have organized also the first real-world evidence study, and you can see the results of patients, also GLP receptor agonist naive, and these results are after 6 months. There was people with very, you can see that they are people also with very high level of HbA1c in the beginning, above 9%, and in the end there was significant reduction in HbA1c minus minus 1.3%, and there was also very good result. There was an increase in attainment of target HbA1c. This meant below 7 point, and you can see that about 47 patients reached that very good level. So we can expect that there will be more results of this as it is preliminary analysis. So let's go to our setting, to our department. These are our patients. You can see a very small study group. It's not a study, but there are 10 persons with diabetes mellitus type 2. You can see they have got various age. They have got various duration of diabetes mellitus type 2 from 1 year to 14 years. They are of various age from 46 to 80 years, and all of them were in the beginning treated with metformin, and we have initiated semaglutide on background of also other therapies. So we have initiated with people treated with DPP-4 inhibitors or SGLT2 inhibitors. So let's go to the first patient. This patient is a man born in 1960. He's a bricklayer. He has never been ill, and he married when he was 40. Very soon they have got 2 children, and he stopped all his sports activities. He was fond of ice hockey, football, etc. But after having children, he was sitting at home, and as he said, he was eating everything what was left on the table. So, of course, he became to be a very fat man, and his body mass index is very bad, how you can see. But when he opened the door of our department in 2016, it was a man with diabetes mellitus type 2, with hypertension, with dyslipidemia, and it was very heavy man with 128 kilograms. In the beginning, we were quite successful with treatment. He wanted to keep the diet recommendation to be not so fat. So he was successfully treated for the first years with metformin and diet. But, you know, maybe from your practice, after 2 years, many patients don't follow your diet recommendation. It was the case of that man. He, again, was a little bit more heavier, and, of course, that was a worse outcome for his HbA1c. So we tried to do something, and he decided to be treated especially for obesity. He didn't want to undergo bariatric surgery, but wanted to pay the cheapest anti-obesity. It is Orlistat in our country, but if somebody likes sweets, likes sacharides, in general, he can't be successful, as you know. So when he came again, so there was again a very bad weight. He was also in a very bad condition as for HbA1c. He refused any injectable therapy. It was possible to prescribe dulaglutide, that has been on our market, but he wanted only tablets. So we decided to help him with his weight with dapagliflozin. So we are here in the April of this year, and we are not successful. What's the reason? That man is a bricklayer. He is working outside, and of course the glucosuric effect of dapagliflozin was very bad for him, so he was not following daily treatment. Sometimes he was using that tablet maybe 1 or 3 times per week. So he refused to go on, and just now he has agreed that he would use some treatment with some injection. So we have decided to go on with semaglutide, that common system of intensification. The first month 0.25 milligrams, and then we went on with 0.5 milligrams. And you can see that there is very good result for him. At the end, after 6 months, we have got a very good result in HbA1c is below 7% DCCT, and his weight is excellent for him. As in our country, such people like that man must pay a very large amount of money. It's about 70 euros per month. He said that he has given his money in a good way, that it was good for him to pay something what is so good for him. The next patient is a man, very young, born in 1973, and he was also like a very hard profession. He's an excavator operator and also a driver of a lorry. So it means irregular work, irregular eating. That man is a man without any regular physical activity, and he has got his obesity more than 15 years. So his diabetes mellitus was diagnosed in the beginning of that year. He was in very bad condition. He had all clear symptoms of hyperglycemia, so polyuria. He was very tired, so it was necessary with this HbA1c and very high glycemia to begin with insulin. So maybe about 3 weeks we had to go on with basal insulin and prandial insulin. Then we went. It was successful, so after those 3 weeks we went to basal insulin metformin. In the end of March it was possible to stop insulin, as the results were very fine, and that man was very good at keeping all diet recommendations, and he was losing his weight. And in the improvement of glycemia was good, but he was said to follow his blood glucose with his glucometer, and if he sees something was wrong, he should phone to our department, and he did it. And in the end of April, there was an increase of his postprandial glucose, so he came to our department, and it is a man with such a work where there is compelling need of therapy with very low risk of hypoglycemia, and of course of not to get again weight gain. So we also offered him semaglutide. He has agreed, and you can see that in the end, after about nearly 6 months of that treatment, we are successful, that there is very low level of HbA1c. I will try. It's 6.3. Maybe you can, if you look the beginning of his therapy and this result, you must say, oh, there's a real danger for retinopathy. But I can make you sure that in the beginning of the treatment, we do eye investigation for all our patients, and we, of course, did it with this patient also after 6 months, and he had no diabetic retinopathy in the beginning of this year, and now it is the same, so no problems. We also use anti-diabetic, other anti-hypertensive treatment for him, so you can see that the result for that man is very good, and he suffers with no hypoglycemia during his job. So go to patient. It's a only woman. It's a woman born in 1968. With it is a former clerk, and her life is not so easy for her. In 2005, she had to be retired for health reasons. She had to undergo breast surgery for breast cancer, and then chemo and radiotherapy. And in the end of this year, she was left to be divorced and childless, and she had to be treated for depression. Everybody of you know what does it mean to take pills against depression. So again, the weight of the patient went really high. So in 2012, she was a patient with diabetes mellitus type 2. I had to be treated. She was also treated for hypertension, dyslipidemia, and of course for depression too. The beginning of the therapy was also very simple. That lady wanted to be in better conditions to get to some lower body weight, so she was treated very successfully with a diet and metformin. But you know that diabetes mellitus is a chronic progressive disease, so after 4 years there was not so good results. There was again a high level of HbA1c. It was 8%. Even she was in a very good condition as for their her body weight. It was lesser than it was in the beginning. Everything what we have done was the therapy with tablets. She didn't want to use some injection therapy. It was possible to use, for example, liraglutide, but she was afraid of it. So we were treating with metformin and gliptin, but in the beginning of this year there was a problem. That lady lost her beloved dog, and the depression of her was again much more worse. So she began again to eat, and of course her glycemia went up. So you can see there is again her weight 126 kilo and high HbA1c. During this time, she agreed that she would use injectable therapy. So she has agreed with semaglutide, and as you can see, we are successful again. The lady was successful to get down her glycemia. The level of HbA1c is 7.2, and of course there is again better weight gain. It is less 5 kilos than it used to be in the beginning of this year. So the last patient is a man born in 1953. Is a man working as an electrician. He works in shift, wears irregular eating. Is a man, there is no regular physical activity, so that's why his obesity is since 85 years, and he has been diagnosed with hypertension and dyslipidemia in the beginning of this century. This man was living in another town than in Ostrava. He was diagnosed with diabetes mellitus type 2 in 2009. It was a man very obese, and when he settled to Ostrava in 2017, he came us with 120 kilos of body weight and with a high level of HbA1c for his age, as it is the man without any complication, it should be much more better. He was treated with sulfonylurea and metformin. At first, we tried to improve his diet, so he was sitting with our nutrition specialist, but it was not so useful as he has got bad habits, so we had to intensify his therapy. Of course, he didn't want to be treated with injections. He was afraid together with his job, so it was again gliptin, and it was used together with metformin and glyclazide. But in the beginning of this year, his body weight was the same, but his results as for HbA1c were very bad for him. So then he decided to use another injectable therapy. He didn't want to be treated with gliflozins, as he has heard that therapy is connected with unpleasant glycosuria. Some of his chemists told it to him. So we have begun with semaglutide, and in the end, after nearly 6 months, there is again very good improvement. He has got his HbA1c below 7%, and you can see that he lost nearly 9 kilos. So what to say in the end, you can see that our patients in our small cohort of patients are at very good level of HbA1c after 6 months. This is the group of patients who had been treated with semaglutide after metformin and diet. This group of patients, these are patients treated with metformin and another peroral antidiabetics. It is especially gliptin, and patient number 8. And these two patients, these are people treated with metformin and two other drugs, and were intensified by semaglutide. So the change of this small group in HbA1c after 6 months is minus 1.3%, and also there is a change in weight after 6 months. It is various from minus 9 kilos to 3 kilos. Most of patients lost 3 kilos, so in average it is about more for 4 kilos. And in the end, I would summarize the results of these patients. I think you have already read it on the table, but we have new recommendation of ADA and EISD for treatment of diabetes mellitus type 2, and there is a very good position for GLP-1 receptor agonists. They are recommended where there is a need to treat people with atherosclerotic coronary disease or chronic nephropathy, but also where there is a need to minimize hypoglycemia or weight gain. I think that all the first patients from our department are people, there is a compelling need to minimize the risk of hypoglycemia, to prevent weight gain, and one of those people is a man with coronary artery disease. And I think that if we look at the results of Sustain 6, they have got a good idea or a good future before for future, as maybe they will be happy to get prevention, e.g. for progressive nephropathy. So the conclusion is that semaglutide has demonstrated potent anti-glycemic effects, but also metabolic effects and cardiovascular benefits. Clinical trial profiles of semaglutide is already supported by early real-world evidence. And in real world, in our department practice setting, GLP-1 receptor agonist naive patients who initiated semaglutide had significant improvement in HbA1c and body weight reduction after 6 months, regardless of concomitant diabetes therapy. So, in the end, I will show you small pictures from the town where I live. It is a town in the north of Moravia, and it's a town connected with steel industry and mine industry. So you can see that our patients were with jobs reminding the town. There are nice monuments, industrial monuments. So if you go to the Czech Republic, don't go only to Prague, go also to Ostrava, where you can finish the visit to attending this now nice cafe on the mine tower that is dedicated to Usain Bolt, a very well-known athlete who has attended Ostrava athletic meeting. So thank you for your attention.
Thank you very much for this very comprehensive lecture. Επειδή και οι δύο μιλητές δεν αφήσανε χρόνο για πολλές ερωτήσεις και θεωρώ πως θα υπάρχουν πολλές, όμως θα επιτρέψουμε να γίνουν στον κάθε μιλητή. Βασίλη, έλα δίπλα μας κι εσύ. Δεν έχουμε χρόνο. Είναι καλύτερα, ωραία, να κάνουμε τη σύνοψη, αλλά πρέπει να απαντήσουμε και σε κάποια ερωτήματα.
Η σύνοψη έχει να κάνει... απλά θα σας πω λίγο για την κυρία Ρατσίκα. Αυτό το οποίο περιέγραψε είναι η πρακτική στην Τσεχία, όπου το φάρμακο δεν έχει ένδειξη για συγχορήγηση με SGLT2 αναστολής, δεν έχει ένδειξη για συγχορήγηση με βασική ινσουλίνη, μόνο η εγκεκριμένη δόση είναι τα 0,5 μιλιγκράμμ. Έτσι, δύσκολα μπορεί να φανταστεί κανένας ότι υπάρχει σύστημα υγείας πιο παράλογο από το δικό μας, αλλά από ό,τι φαίνεται μάλλον υπάρχει. Όταν το φάρμακο θα έρθει στην Ελλάδα, αναμένεται μέσα στους επόμενους μήνες, θα μπορεί να χρησιμοποιηθεί σαν δεύτερο βήμα αμέσως μετά τη μετφορμίνη ή σαν τρίτο βήμα μετά από οποιοδήποτε αντιδιαβητικό φάρμακο, μπορεί να συνδυαστεί με SGLT2 αναστολής, μπορεί να υποκαταστήσει τη βασική ινσουλίνη, μπορεί να συγχορηγηθεί με βασική
Βασίλη,
ινσουλίνη.
συγγνώμη, να κάνουμε λίγο τις ερωτήσεις και να κάνουμε το conclusion μετά.
Conclusion μετά τις ερωτήσεις.
Ναι, μετά τις ερωτήσεις, γιατί αυτά που λέμε τώρα, αν κυκλοφορεί στην Τσεχία ή όχι η Σεμαγλουτίδη, θα κυκλοφορήσει και στην Ελλάδα. Εν πάση περιπτώσει, ένα δευτερόλεπτο σου επιτρέπω.
Ναι. Λοιπόν, η περιορισμένη κλινική εμπειρία που έχω αφορούσε τη μελέτη λοιπόν Sustain 7. Ήταν μια μελέτη στην οποία η Σεμαγλουτίδη συγκρίθηκε με την ντουλαγλουτίδη. Στους ασθενείς τους οποίους είχαμε, το σημαντικό είναι ότι πέτυχαν όλοι το στόχο της αντιδιαβητικής αγωγής χωρίς ανεπιθύμητες ενέργειες. Και το πιο σημαντικό απ' όλα είναι ότι όταν η μελέτη τέλειωσε και τους προσφέραμε τη δυνατότητα να μπουν πια σε όποια αντιδιαβητική αγωγή ήθελαν, όλοι οι ασθενείς επέλεξαν να συνεχίσουν με GLP-1 ανάλογο. Έτσι. Πράγμα το οποίο νομίζω ότι λέει πολλά πράγματα και για την αποτελεσματικότητα και για την επίδραση στο σωματικό βάρος, αλλά και για την ασφάλεια και την ποιότητα ζωής όπως την αισθάνονται οι ασθενείς. Αυτά.
Λοιπόν, έλα και εσύ δίπλα μας τώρα. Υπάρχουν ερωτήσεις, σχόλια, ο κύριος Μιγδάλης.
Να συγχαρώ και τους δύο ομιλητές, αλλά θα ήθελα λίγο να σταθώ στον κύριο Τσιμιχόδημο. Η κυρία μελέτη που έδειξες, Βασίλη, ήταν η Sustain 6. Γνωρίζουμε σε όλες τις μελέτες είναι μελέτες μη κατωτερότητος και πρέπει η γλυκοσλιωμένη, η γλυκαιμική ρύθμιση, η αντιπερτασική αγωγή και η πολυπιδεμική αγωγή να είναι παρόμοια ακριβώς για να δει το ζητούμενο. Έχω την αίσθηση ότι η μεγάλη διαφορά στην γλυκοζηλιωμένη αιμοσφαιρίνη που επετεύθηκε ήταν το μεγάλο μειονέκτημα της Sustain 6 και όχι το πλεονέκτημα. Όφυλαν οι ερευνητές και είχαν τη δυνατότητα και οι μεν και οι δε με οποιοδήποτε μέσο να έχουν μικρές διαφορές. Δεν ήταν στόχος να δείξει υπεροχή superiority, ήταν non-inferiority και επειδή αντιλαμβάνομαι ότι την έχεις μελετήσει, θα ήθελα λίγο τη γνώμη σου σε αυτό το πολύ σημαντικό σημείο. Ναι,
ο κύριος Μιγδάλης έχει απόλυτο δίκιο. Το ζήτημα είναι ότι σε όλες τις μελέτες καρδιαγγειακής ασφάλειας, σε όλες τις ΣΥΒΟΤ, το επιδιωκόμενο, η επιδιωκόμενη υπογλυκαιμική ισοδυναμία δεν επιτυγχάνεται. Ναι. Σε καμία μελέτη, λοιπόν, δεν έχει επιτευχθεί, ούτε αν ψάξετε όλες τις ΣΥΒΟΤ που έχουν δημοσιευτεί την τελευταία δεκαετία, πάντα ο παράγοντας υπομελέτη είναι πιο ισχυρός. Εδώ μιλάμε για ένα πολύ αποτελεσματικό φάρμακο. Επίσης, επειδή πρόκειται για μελέτη η οποία είναι σε εξέλιξη, από ό,τι θα είδατε, οι καμπύλες αρχίζουν να προσεγγίζουν. Άρα, λοιπόν, προς το τέλος της μελέτης, νομίζω ότι το χάσμα θα μειωθεί. Παρόλα αυτά, δεν είμαι σίγουρος ότι θα μπορέσουμε να πετύχουμε ισοδυναμία.
Άλλες ερωτήσεις, σχόλια από το ακροατήριο?
Να ρωτήσω εγώ κάτι λίγο το Βασίλη. Βασίλη, μας είπες λίγο για την διαβητική αμφισβητοπάθεια. Ξέρουμε ότι το φαινόμενο κρατάει 2 χρόνια περίπου. Υπάρχουν κάποια δεδομένα για το τι έγινε μετά, αν βελτιώθηκε η αμφισβητοπάθεια, τέλος πάντων?
Δεδομένα ακόμη δεν έχουμε. Αυτό το οποίο ξέρουμε από προηγούμενες μελέτες είναι ότι αυτή η επιδείνωση της διαβητικής αμφισβητοπάθειας είναι συνήθως πρόσκαιρη. Είναι κάτι το οποίο υποχωρεί και στο τέλος, συνήθως, οι ασθενείς που εμφάνισαν τη μεγάλη γλυκαιμική μείωση καταλήγουν να έχουν καλύτερη όραση από τους υπόλοιπους. Τουλάχιστον αυτό έγινε σε προηγούμενες μελέτες, στην DCCT, στο UKPDS κτλ.
Άλλες ερωτήσεις, σχόλια? Να ρωτήσω εγώ στην κυρία Ρατσίσκα. Is obesity actually a key point before initiating GLP-1 receptor agonists or not? All of your patients were obese.
Yes. In our country, it's not so easy to prescribe the patients semaglutide or other GLP-1 receptor agonists. There are 2 levels of payment from the side of the reimbursement from insurance companies aren't the same. We have got so lower level of reimbursement from the company. 1/2 is paid by the company, the second half is paid by patient. If there are conditions for better payment for patients, he must be obese, so he must have his obesity at the grade number 3, and then he can, number 2 is more than 35 body mass index, and then he will pay only 80. The insurance company will pay about 80% of the price, and the patient will pay 20% of the price. So obesity is really, it's not good. We know that obesity above 35 is the target. We know that we are successful to initiate the therapy much more earlier, not to wait for obesity, etc. But it is rule, it is stated by the state. It's a state rule, so we must keep it.
Thank you very much. And υπάρχουν άλλες ερωτήσεις, σχόλια? Μία ερώτηση ακόμα εγώ θέλω να κάνω όμως στην προσκεκλημένη ομιλήτριά μας. How often your patients complain about side effects?
I am very satisfied that there are very, very low percent of some side effects. Semaglutide is very well tolerated. In the beginning, there is maybe for some days only nausea, but no other problems. So none of our patients, I have got more patients than those 10, have interrupted the therapy due to some side effects.
Εάν δεν υπάρχουν ερωτήσεις και σχόλια, να ευχαριστήσουμε καταρχήν τους 2 ομιλητές, την εταιρεία Novo Nordisk, αλλά και όλους εσάς για την υπομονή σας. Από ό,τι είδατε, είναι ένα φάρμακο πολλά υποσχόμενο, όπως και όλη η κατηγορία αυτή των φαρμάκων, γιατί με μία ένεση την εβδομάδα έχει στα καλά αποτελέσματα, πολλαπλά ωφέλη για τους αρρώστους, διότι δεν κοιτάμε μόνο την γλυκοσλιωμένη, παράλληλα κοιτάμε και τις συνοσυρότητες και από ό,τι είδατε τα παραδείγματα της προσκεκλημένης ομιλήτριας είχαν όλες τις συνοσυρότητες, αλλά ακόμα και την κακοήθεια, από ό,τι είδατε στο τελευταίο παράδειγμα. Επίσης, να τονίσω και αυτό που είπε και ο Βασίλης, πολύ σημαντικό για τη μείωση των τριγλικεριδίων, που είναι πραγματικά ανεξάρτητος παράγοντας κινδύνου. Άρα, λοιπόν, ως ο νούπο θα έχουμε το φάρμακο αυτό και στην Ελλάδα και από ό,τι γνωρίζουμε θα μπορέσουμε σύντομα να το χρησιμοποιήσουμε στους ασθενείς μας στην καθημερινή κλινική πρακτική. Σας ευχαριστώ όλους για την υπομονή σας.